Okay, a very warm welcome from the European Association of Urology on this webinar on antibiotic prophylaxis on urological interventions. Antimicrobial resistance is a global health burden already, and you also know that urinary tract infections are the most common bacterial infections in human beings. So we as urologists can do something about the antimicrobial resistance development. And therefore, we have this webinar talking about antibiotic prophylaxis in urological interventions. And we have a really good international faculty from Italy, from Spain, and also Switzerland. And we will have here talks about the interventions in stone therapy and stone surgery and prostate biopsy, which carry the highest risk of infection. And we also will have a talk about extending antimicrobial prophylaxis from an infectiologist. So I will hand over to my co-chair, who will introduce our speakers, and then the space discussion.
Hello, good morning, everybody, and welcome to the EAU webinar. We are happy to share the webinar with some urologists and some infectiology disease faculty, as we have to collaborate together. So remember that you can ask a question. There are the question and answer icons in the Zoom, so you can ask the question you want, and we will try to ask all of them at the end of the webinar. So in order to don't lose more time, we are going to start. The first speaker is Elisa de Lorenzis from the University Hospital in Milano, and the speak is the lesson from the American Urological Association and European Association of Urology Guidelines and the appeal trial for the antibiotic prophylaxis in stone surgery and SYL. So Lisa, you can start.
Thank you for the presentation and good afternoon to everyone. I would like to thank EAU section of Infectional Urology for involving me in this webinar. Since the topic is very dense and the time is short, let's begin. The goal of antibiotic prophylaxis is to reduce the risk of surgical site infection. However, when we talk about endoscopic procedure, the endpoints we will focus on are symptomatic UTI, febrile UTI, bloodstream infection, urosepsis, and pyelonephritis. Because bacteriuria alone is not usually a clinically relevant outcome. Before deciding whether to perform antibiotic prophylaxis, is useful to understand how is the rate of infection complication without antibiotic prophylaxis. And among urological procedures, the stone surgeries show the highest rate of febrile and symptomatic UTI, especially PCNL. The principles of antibiotic prophylaxis examine the question who, what, where, when, and how long. And today we will focus on who and what. We know that there are several patient-related risk factors that may lead us to consider antibiotic prophylaxis. We have different classification. For example, we can use the Oreno classification, even if it's a little bit old. But the most important thing is that when we are talking about stone surgery, we must remember that we can have a lot of coexisting risk factors that can make the patient more vulnerable. For example, we can have obstruction, hydronephrosis, recurrent UTI due to colonization, and we can have a lot of foreign bodies like nephrostomy tube or double J stents. To decide in which procedure antibiotic prophylaxis should be performed, we start obviously from the surgical wound classification, which has been modified in 2019 by the best practice policy statement of EAU. And by definition, endoscopic procedure are clean contaminated class 2 procedure. And in this classification, infected stone procedure are by definition contaminated and belong to class 3. However, infection stones, infected stone, or infectious stone can have a lot of interpretations. We can consider, for example, struvite stones due to urinary tract infection with urease-producing bacteria. We can have secondary infected stones of any composition, and these stones will be positive for the stone culture after our surgery. We can have stone obstructing the urinary tract leading to pyelonephritis, for example. Usually, class 2 urological procedure cannot be fully categorized by site surgical infection. And so, again, the AUA best practice policy statement proposed a revised classification that merged the wound classification and procedure-related risk, providing a framework for deciding whether antibiotic prophylaxis is indicated or not. And so, shockwave lithotripsy is considered a low-risk procedure, and in this case, single-dose antibiotic prophylaxis may not be necessary. Ureteroscopy with lithotripsy or litholapaxy is an intermediate risk procedure, and in this case, a single dose of antibiotic prophylaxis is recommended. And PCNL is defined as a high-risk procedure at the same level of a transrectal prostate biopsy. And of course, in this case, again, antibiotic prophylaxis is recommended for this procedure. Of note, in case of obstructive urolithiasis, that is a very common scenario, this procedure can be reclassified into dirty procedure, class 4 procedure intraoperatively, and this obviously is a higher risk for postoperative infectious complications. We have also procedure-related risk factors, and for example, longer operative time, the need for multiple percutaneous tracts, an incomplete stone clearance can increase the likelihood, again, of postoperative infectious complications. Now, we can review the indication of the guidelines. For shockwave lithotripsy, the EAU Guidelines on Urological Infection do not recommend antibiotic prophylaxis with a strong evidence. But in the EAU Guidelines on Urolithiasis, antibiotic prophylaxis is recommended in presence of increased bacterial burden, for example, in patients with indwelling catheter, nephrostomy tube, or infected stones. The AUA best practice policy statement consider antibiotic prophylaxis only in the presence of risk factors, but these risk factors are quite general and not specifically tailored to stone surgery. The strong recommendation against antibiotic prophylaxis in the EAU guidelines are based on several studies and some with methodological issues. This is a meta-analysis that is quite old, is from 2012, and we have no differences in terms of symptoms, fever, and UTI incidence with or without antibiotic prophylaxis. Then we have this systematic review from the Canadian Urological Association Guidelines panel, and they conclude that prophylaxis should be considered in patients at high risk of infectious complication, and in this case are included some stone-related risk factors like the stone burden, the presence of pyuria, and also the need for other operative procedure, including stent. Then we have this randomized controlled trial with a limited sample size, in which, again, we don't have any difference with or without antibiotic prophylaxis in terms of pyuria and bacteriuria and febrile UTI. This is the most recent meta-analysis that conclude that after the exclusion of high risk of bias studies, we don't have any differences in terms of asymptomatic bacteriuria and clinical UTI in patients with or without receiving antibiotic prophylaxis or not. However, some of these studies has a small number of events which make them potentially underpowered. And basing on this limitation, the appeal trial was designed. And this is a very recent blinded randomized multi-center trial that evaluates antibiotic prophylaxis with a single dose of ciprofloxacin versus placebo in countries where fluoroquinolones resistance is not a major issue. Patients with a positive preoperative urine culture were excluded, but were included patients with an indwelling urethral stent. In this trial, the primary outcome was a composite of asymptomatic bacteriuria, symptomatic cystitis, and pyelonephritis or urosepsis. And we don't have any differences between the two groups considering this outcome. Again, we don't have any difference in the incidence of a symptomatic UTI between the two groups. But in the placebo groups, we have a higher rate of pyelonephritis. And of note, no patients developed urosepsis, no patient died, and no patient experienced a serious adverse event. So the conclusion of this trial is that antibiotic prophylaxis with single-dose ciprofloxacin probably reduce post-procedural infections, including serious events such as pyelonephritis. But because the absolute benefit is modest, individual patient risk and preferences should guide prophylaxis decisions. Regarding ureteroscopy, EAU guidelines on urological infection recommend prophylaxis with a weak evidence because this is based on low quality data. But in the EAU guidelines on urolithiasis, we have a recommendation about offer perioperative antibiotic prophylaxis to all patients undergoing endourological treatment with a strong strength rating. The EAUA guidelines recommend a single dose prophylaxis to all cases of ureteroscopy. Some of this evidence from the EAU guidelines is based on this meta-analysis, including more than 4,500 patients. And we have has results that preoperative antibiotic prophylaxis doesn't reduce the risk of postoperative febrile UTI, but we have a reduction of pyuria and bacteriuria. Then we have this randomized control trial in which the standard antibiotic prophylaxis is compared to prophylaxis with fosfomycin, and we have no differences in terms of infectious complication between these two groups. And then we have this interesting randomized control trial in which 3 different antibiotic prophylaxis regimens are compared. We have group 1 with no antibiotic prophylaxis. We have the group 2 with a single dose of ciprofloxacin. And then we have a group 3 with 2 doses of antibiotic prophylaxis. So we have an extended prophylaxis with a second dose within 6 hours after retrograde intrarenal surgery. And of note, we have no clinical differences between the 3 groups in the incidence of systemic inflammatory response syndrome, but we have a higher risk of SIRS in patients who receive no antibiotic prophylaxis with a greater area of stones. Then for PCNL, both EAU and AUA guidelines recommended a single dose antibiotic prophylaxis. And this recommendation is based on this systematic review and meta-analysis. We include more than 1,500 patients. And again, we have different antibiotic strategies. We have a single dose antibiotic prophylaxis. We have an extended therapy in the preoperative period and extended therapy in the postoperative period. And compared with single dose before anesthesia, preoperative prophylactic antibiotics reduce sepsis and fever. And on the other hand, patients receiving postoperative prophylactic antibiotics were at significantly high risk of fever. The consensus on performing antibiotic prophylaxis before PCNL is based on the not negligible risk of fever, SIRS, and sepsis reported in literature after PCNL. Obviously, this is not surprising because PCNL intrinsically carries the risk of introducing bacteria into the systemic circulation because we are performing a puncture through the skin. We are creating a communication between the skin and the urinary system, and we are performing a vascular damage. And usually we're dealing with the larger obstructing and infected stones. And depending on the instrumentation that we are using, we can increase the intrarenal pressure and again cause a backflow that again higher the risk of infectious complication. So in conclusion, antibiotic prophylaxis before shockwave lithotripsy is not recommended in standard low-risk patients, but the appeal trial raises some questions. Before uteroscopy, prophylaxis is indicated, even if the supporting evidence remains of low quality. And regarding PCNL, there is no debate for the need for antibiotic prophylaxis before the procedure, but it's still unclear whether it should be extended preoperatively, for example, in high-risk patients or in case of positive urine culture. But at present, evidence suggests that continuing antibiotic postoperatively, for example, the nephrostomy tube removal, is not beneficial. And ultimately, we must remember always that both the patient and the stones make the real difference. Thank you.
Thank you very much, Elisa. Very good presentation. And it's interesting that we probably comment in the following presentation and in the question that quinolones as a frequently used antibiotic, and the guideline and the regulation told not use quinolone as prophylaxis, but we maybe comment at the end. We are going to also talk about quinolones in the following session about the prostate biopsy. First of all, the communication, but Dr. Slan from Bern, that is a strategy for antibiotic prophylaxis in prostate biopsy. He had a very good meta-analysis published some months ago and had a lot of experience about them, as he also a member of the European Association of Urology section of infection and also in the guidelines. Go ahead, Fabian.
Thank you very much for the kind introduction. So let's jump right into it. Today, I want to talk about strategies for antibiotic prophylaxis in prostate biopsy, transperineally and transrectally, so both approaches. I have no potential conflicts of interest regarding this talk. To set the scene for this talk, the background is, of course, that transrectal and transperineal biopsy is a highly debated topic that we've been discussing in the last few years at all the congresses. And we've been a mainstay and a staple in prostate cancer diagnosis. Prostate biopsies are performed quite regularly all over the planet, with about 2 million biopsies in the EU and the US each year. So every infection, every post-bioptic infection is very relevant, and it should be a concern to every urologist. As of now, we have conflicting recommendations from the major guideline bodies on when and how we should perform prophylaxis and which approach is best. I will come to this a little later, especially from the two major organizations, the EAU and the AUA. Sepsis and infections with multi-drug resistant organisms after prostate biopsy are very serious complications with a significant burden of morbidity and mortality. And as Lila in the introduction perfectly stated, the rise in antimicrobial resistance is a major concern. And if we look at the O'Neill report, another thing we've been discussing a lot in the last few years, deaths from antimicrobial resistance will surpass cancer if we follow the rate as of now in 2050. In the last 2 years, we had quite a good number of high-quality RCTs and meta-analysis discussing this topic, adding new and high-quality evidence. Jump into our guidelines, the EAU guidelines, we can clearly see a few very strong recommendations from the guidelines panel. First, it says use the transperineal approach whenever possible for the low risk of infections with a strong rating. We should use povidone iodine preparation before transrectal biopsy if we have to do it. We should not use fluoroquinolones according to the EMA since 2019, so same thing for the last 6 years, more or less. And for antibiotic prophylaxis in transrectal biopsy, we shouldn't just choose a one-size-fits-all concept. We should always go for a tailored approach. In transrectal biopsy, it's especially important to really look at our patient cohort, take a detailed history of our patient, background of antimicrobial therapy in the months before the prostate biopsy, maybe if it's a patient from a nursing facility or anything else. All these factors should influence antibiotic prophylaxis. And we should always go for targeted prophylaxis. That's what the guideline panel is highly recommending, or for augmented prophylaxis with 2 or more classes of antibiotics. And when we go into the flowchart in the guidelines, we can clearly see first and second choice. So the EAU is very clear about the route of biopsy, and transperineal should be the way to go, with perineal cleansing, removal of the hair at the perineum, and if necessary, antibiotic prophylaxis. This will be a recommendation that will be slightly changed in the next guidelines, but the evidence is not as abundant as of now, even though we have quite a few new RCTs discussing the matter. So let's jump into the latest data in transrectal and transperineal biopsy. I think we all know the RCTs that came out last year mostly, where we can clearly see a benefit for the transperineal prostate biopsy. The only outlier in this cohort of RCTs is the ProPC trial out of North America, which didn't show any reduction of infectious complications with the transperineal approach. There is one very important thing to say for all these trials. In the trials, they didn't use antibiotic prophylaxis for transperineal biopsy, but they did use an abundance of antibiotics in the transrectal biopsy group. So all the patients who underwent transrectal biopsy either got targeted prophylaxis or, in some cases, augmented prophylaxis or multiple drugs up to carbapenems to avoid postbiotic infection, and were mainly based on fluoroquinolones, which we shouldn't use for the sheer prophylaxis in any kind of surgery. Same goes for standard aminopenicillins. We should use niche antibiotics to lower the burden of resistance for these kinds. What we can also see is that the risk of sepsis, that's something that goes a little against our historic knowledge of prostate biopsy, is quite low, even in the transrectal biopsy group. But if we think about 2 million biopsies a year and a sepsis rate of 0.1 or 0.5 or 1% makes a very important difference. And all the trials that have been published in the last 24 months or so have been underpowered to detect a certain amount of sepsis. So if we design future trials, anybody of our listeners today, they should be adequately powered to address the matter. One major problem I have with the ProPC trial is the way how they detected infections, and that's very important issue with any kind of trials in infectious diseases, because you need to have a very stringent follow-up, and it needs to be pre-specified on what outcomes you are measuring, as Elisa elaborated in the last talk. And if you have a phone call after 30 days and ask the patient, have you had any kind of fever? That's a valid point and a valid question to ask. But it's a very difficult question to ask during COVID. So that's just my note for this trial. If we go in the transrectal prostate biopsy, there haven't been as many big RCTs, but there have been a few good prospective trials investigating prophylaxis regimen. And we can clearly see that there is quite a significant jump in infectious complications. And even if you look at the large retrospective cohorts that have been prospectively collected but retrospectively analyzed from the last 12 months, we can see that this in infection rate is more or less consistent between all those trials. There are always outliers, as in the Turkish publication, which comes down to the kind of needle disinfectant with formalin and the very high rate of post-bioptic infection. When we have a look at the aggregated evidence, so into meta-analysis and systematic reviews from the last year, one of the very, very important ones is the one by a German group, Wolf et al., that investigated transperineal biopsy with and without prophylaxis and didn't see a difference. So this is more or less replicating what the NoRep trial in 2021 already showed us out of Scandinavia, that it doesn't really add any value to add antibiotic prophylaxis in transperineal biopsy. If we look at the Satoni paper published last year in European Urology Oncology, they were primarily looking into cancer-specific outcomes, so the detection rate of prostate cancer, but they didn't find any difference in post-bioptic infection. Notably, this trial did not include the translate trial and the full results from the PREVENT trial, so it's not offering a full scope on the topic. And the last one, or the most recent one that has been published, was by our group, so the guidelines panel, the EAU and the Young Academic Urologist. Big shout out to him for this work. And we have shown that if we're just investigating RCTs and we tried to offer level 1A evidence, we can see quite a significant reduction in one of the most important outcomes of post-bioptic infection, so serious infection, sepsis, systemic urinary tract infection, and so on. And we have shown that there is a 77% reduction in the odds of hospitalization after prostate biopsy with the transperineal approach, with most of the trials not utilizing antibiotic prophylaxis. And I think this is a very important message, and that's what we've been hammering down on from the guidelines panel and from the EAU in the last years, that it's about sparing antibiotics and it's about reducing serious infections. And the transperineal approach is a very simple and easy way to do so. If we take a step back and think about prostate biopsy from the transrectal approach, we still acknowledge that there are areas on the world where there is limited access to transperineal biopsy. You don't have the necessary instruments, you don't have the necessary ultrasounds, or you don't have the necessary training to do so. So it's not the first line access. But we have to say, and we have to acknowledge, and I think also understand from a socioeconomic standpoint, that if you need to do transrectal biopsy, it is feasible, but you should take proper precautionary measures and preventative measures. A key message, more or less, from this talk is it's not about the antibiotic prophylaxis, it's about the route of biopsy that's way more important than any prophylactic regimen we could choose. In the transperineal prostate biopsy, currently no prophylaxis should be the standard of care in most patients. Not in all patients, but in most patients. It's highly debated to give antimicrobial prophylaxis before the biopsy, but it is recommended in high-risk patients. And the problem with high-risk patients, it's a term that's always thrown out there, but it's never really outlined. So who is high risk is a question we've been asking ourselves, and we are currently running Delphi consensus multidisciplinary from all over the world, more or less, with many, many different specialists. And I'm just giving you a little peek in the first results. We have gained insight into the first round, where we already reached consensus. And the panel with top experts from the world, from urology, microbiology, infectious diseases, and so on, is quite certain that patients with immunosuppression, indwelling catheters, more or less a given, recurring urinary tract infections or chronic prostatitis, poorly regulated diabetes, and a history of post-bioptic infection should undergo antimicrobial prophylaxis in transperineal prostate biopsy, which accounts for a small proportion of all biopsies. So to sum up my talk and to bring it together, again, my recommendation and something I'm very passionate about is switch to the transperineal approach. It's very easy to do. The learning curve is very flat. It's a quick one. Yes, it carries a little more pain if you do it on a local anesthesia, but it's perfectly feasible. Be very, very critical about your patient's history. I think it's important that if you do a prostate biopsy, you know the history of your patient. You should have a very strategic approach to it, and we try to implement this in our center as well. You should have a look at the comorbidities. You should know your resistance rates locally, because they differ amongst Europe vastly, more or less. You should also know about the socioeconomic influences. So where is the patient? Where does he come from background? And in transrectal biopsy, you should always go for a tailored approach. So no one-size-fits-all concept. Do not just go for ciprofloxacin because it's the easiest, most convenient, and of course, best studied option, because there are other options. We should go for swabs. We should go for rectal swabs, for perineal swabs, for stool cultures, and do a tailored approach. We should always prep the rectum with povidone, because it's one of the most important non-antimicrobial measures to avoid infection. So my last message is everything I just said is perfectly delineated in the guidelines. It's summarized in more or less 2 tables and 1 flowchart, and that's what we should stick to. And that's what I encourage you all to do. And now I'm very grateful for this talk, and thank you all for the attendance. I think we will do the questions afterward. Thank you very much.
Thank you very much, Fabian. A very interesting presentation. And now I have to move on to the next presentation. It's a pleasure to have in our webinar not only the urologists are responsible of the infections, and we need collaboration with the infectious disease specialist, and we had Dr. Cajada, that is the head of the infectious disease department in Hospital del Mar in Barcelona, that is going to talk about there is such a thing as extended prophylaxis. Fabian introduced the topic, that is an important issue to deal. So, Dr. Cajada, you had your time for the presentation. Thank you very much.
Thank you. Thank you for inviting me. I'm very, very proud to be here. Absolutely grateful to the European Society of Urology. The title of my presentation is "There is such a thing as extended prophylaxis." These are my general conflict of interest. First of all, we're going to talk about the definition of extended or prolonged prophylaxis and its consequences. After that, we will review meta-analysis, big meta-analysis regarding continuation of prophylaxis in general in surgery. And we will center in these interventions that the webinar is about, interventions for urinary stone treatment, if we need or not prolonged prophylaxis, and prostate biopsy, if we need or not prolonged prophylaxis. What is extended or prolonged prophylaxis? The definition is antibiotic prophylaxis beyond the skin closure or more than 24 hours post-operative. First of all, we have to know that there is no high level of evidence to support the use of multiple doses of antimicrobials in the absence of preoperative symptomatic infection. Moderate quality evidence from multiple randomized control trials does not show a benefit of prolonging prophylaxis beyond the case completion. I'm including all types of surgery. The continuation of antimicrobial prophylaxis beyond a single perioperative dose has been associated with a 4% risk of subsequent Clostridial infections in one randomized control trial. This is one of the consequences of prolonged post-operative or perioperative dose. And very important is that prolonged antibiotic prophylaxis has been significantly associated with an increased risk of acquiring antibiotic resistance, while conferring no decrease in surgical site infections. This is the meta-analysis I was talking about, published in the Lancet Infectious Disease with around 20,000 participants, with results from more than 52 randomized control trials. And in the end, the post-operative continuation of antibiotic prophylaxis did not yield any additional benefit in reducing the incidence of surgical site infections. These findings support the WHO recommendations against this practice. This practice, the prolonged antimicrobial prophylaxis, is discouraged in general, not only by the WHO, but also by the CDC and other institutions. What about surgery? What about urology and these interventions for urinary stone treatment? Of course, extracorporeal shock wave lithotripsy in patients with sterile urine in different meta-analyses demonstrated that there is no advantage of any antimicrobial prophylaxis in post-procedure infections, no benefit in post-procedure fever, no benefit in post-procedure clinical UTI also in this meta-analysis compared with placebo. So in general, extracorporeal shockwave lithotripsy in the meta-analysis does not need any prophylaxis antibiotic, except in the new appeal randomized control trial, which is even in press now. It's been published, which of course is a very well done clinical trial demonstrating that one dose of ciprofloxacin reduces the incidence of pyelonephritis in patients in comparison with patients receiving placebo. But no extended prophylaxis is contemplated in this situation. What about percutaneous nephrolithotomy? There is a meta-analysis comparing patients treated with antibiotics with pre-op prophylaxis in comparison with a control group without antimicrobial prophylaxis. And there was a benefit of preoperative prophylaxis in patients comparative with a control group. However, post-operative prophylaxis augmented the risk of infection in these patients. And when they compare a single dose versus an extended dose in the meta-analysis, the post-procedure fever was not different in patients receiving a single dose or extended dose. However, in this meta-analysis, patients with high risk, which were defined as big stones or pelvic lithial dilatation or previous UTI, in these high-risk patients, extended dose work better than single dose, preventing the development of shears after the procedure. This is the only one situation in a meta-analysis that promotes the extended dose. In another interesting meta-analysis, comparing patients with antibiotics extended dose until tube withdrawal, the demonstration of the frequency of fever after the procedure was similar in patients with extended dose until tube withdrawal in comparison with patients without extended dose. So the incidence of fever was the same. The same happened with sepsis or SIRS in these patients undergoing extended dose versus non-extended dose of prophylaxis antimicrobials in percutaneous nephrolithotomy. In another recent meta-analysis, these patients were treated with preoperative 7 days antibiotic treatment, and this prevented the development of SIRS or sepsis. Some of these patients, or some of these studies, some patients did not have a sterile urine. So in my opinion, the effect of this preoperative prolonged therapy was because they were treating also patients with bacteriuria. These patients did not have different incidence of fever, but positive urine cultures were more frequent in patients not receiving preoperative prophylaxis. Regarding ureteroscopy stone removal, there is a very old clinical trial, but this is one of the most cited, comparing 1 dose of levofloxacin versus no prophylaxis. The number of patients was small, but the complications were the same in both, but postoperative significant bacteriuria was more frequent in patients without prophylaxis, and nosocomial bacteriurias were more frequent. However, a more recent study comparing, but this was a retrospective one, of 400 consecutive patients who underwent ureteroscopy with or without prolonged perioperative antibiotics, the duration of the preoperative antibiotics did not affect the infectious complication rate. So prolonged prophylaxis, even if it's preoperative, is not recommended in this. When they compare antibiotics versus non-antibiotics, of course, bacteriuria was more frequent in patients not receiving prophylactic antibiotics, but a single dose of antibiotics was the same if it was performed 1 hour before or 1 hour after the surgery, because the differences were not significant. And this study tried to compare patients adding or not post-operative antibiotics, which is some kind of prolonged antibiotics prophylaxis. This is a retrospective review of consecutive patients undergoing ureteroscopic stone treatment, and all patients received a single dose of antibiotics before ureteroscopy. A subset of patients was also given postoperative antibiotics. However, the differences between those groups were not statistically significant. So the conclusion is that a single preoperative dose is sufficient. It does not need to give additional postoperative antibiotics because they don't decrease the infection rates. Regarding transperineal prostate biopsy, we have reviewing that the incidence of fever with antibiotics or not antibiotics in this meta-analysis was the same, and the incidence of infections was the same receiving antibiotics or non-antibiotics, and the same happens with the incidence of sepsis or the incidence of readmission for infections. In this meta-analysis of several studies, including a total around of 3,000 patients, there were no differences in transperineal prostatic biopsies in the incidence of infections with antibiotics or without antibiotics. In this meta-analysis of 100 studies with around 40,000 men, comparing patients receiving antibiotic prophylaxis or not, infections were more or less similar in both groups, But interestingly, sub-analysis of patients with low biopsy core stratum, the rates of sepsis were comparable, but the rate of infections was higher in the non-prophylaxis antimicrobial group. So we are telling about 0.5 in non-antibiotic, and in antibiotics, sorry, and 1.2 in antibiotic prophylaxis, with a statistical significant difference. This is another study comparing patients with and without antibiotic prophylaxis, and the infections were similar in both groups, and the differences were not statistically significant. Regarding transrectal prostate biopsy, a meta-analysis of 2,000 men with shorter prophylaxis compared with longer prophylaxis. Here they are comparing short-term with long-term prophylaxis. There was a significant difference between long-term and short-term prophylaxis. Interestingly, it should be noted that all studies used fluoroquinolones in this context, which is something that we have to discuss later. In this study, in this meta-analysis, which is also in transrectal prostate biopsies, it is a very interesting study because they compare different situations. They compare single shot versus 1 day, which were no difference, single shot versus 3 days, which benefit 3 days. They compared 1 day versus 3 days, which were comparable, and they compared 1 day versus 5 to 7 days, which were superior the extended prophylaxis, but it was based only in one study from 1996, which has been criticized. And in summarizing this data, this meta-analysis, what is recommended in transrectal prostate biopsy is a full 1 day prophylaxis, because even the longer prophylaxis was superior. It was based in only one study from 1996, and 1 full day was comparable to 3 days prophylaxis. So finishing my talk, we can, regarding the extension of prophylaxis, the American Urology Association, they don't talk about extended prophylaxis in any situation. They say that shockwave lithotripsy is only single 1 dose, only if risk factors, as we saw before. Percutaneous nephrolithotomy is recommended less than 24 hours prophylaxis, which is not considered prolonged, but it is not a single dose. Ureteroscopy is recommended a single dose, and transrectal prostate biopsy, this is not the, they say a single dose, the American guidelines. Regarding the European Urology Association, they talk about the not need of antibiotic prophylaxis in lithotripsy. They also promote 1 dose in ureteroscopy. Meta-analysis of randomized controlled trials with moderate level of evidence. They said that prophylaxis before PNL was necessary, but no, they don't talk about extended prophylaxis. And the same happened with transperineal biopsy, which they say it's independent of the antibiotic prophylaxis. The incidence of infections were similar. So in conclusion, prolonged antimicrobial prophylaxis is discouraged in general. Extracorporeal shock wave lithotripsy do not deserve prolonged prophylaxis, and even we can discuss if it needs any prophylaxis. Percutaneous nephrolithotomy deserves less than 24 hours prophylaxis. We could discuss about high-risk patients if they need or not prolonged prophylaxis based in that meta-analysis that we commented before. And in my opinion, patients with positive urine culture that are going to be undergoing percutaneous nephrotolectomy, maybe they will need the treatment of this this previous bacteriuria. Ureteroscopy stone removal deserves a single pre-op dose, but not prolonged dose. Transperineal prostate biopsies, no prolonged prophylaxis or no prophylaxis, depending on the risk of the patients, as our colleague said before. And transrectal prostate biopsy deserves prophylaxis, but less than 24 hours. Thank you very much for your attention.
Thank you very much, Dr. Orcajada. There are some questions in the chat, but most of them are being answered online. But at the end, we want to also introduce a clinical case that sometimes is the best to go to the practical issues. So Fabian Stan is going to present with Laila a clinical case.
Yeah, I think Fabian shares the screen and he will present an interesting case in transrectal prostate biopsy.
I will try to make it quick in order to have a discussion afterwards. But what I want to do is use the talks we had now, very interesting, great talks by my colleagues, to take a learning case. And a case that happened a few months ago with the last follow-up only 2 weeks ago. And the case is shared with the patient's consent, anonymized, of course. Let's jump right into it. So we discussed a patient, that's how ChatGPT imagines a classical Central Swiss patient in his 60s who has minor LUTs and a history of chronic prostatitis and underwent an MRI for elevated PSA with a pyrite-3 lesion. Otherwise, healthy patient, no relevant comorbidities and no symptoms at time being. The patient underwent the transrectal prostate biopsy at an outpatient urologist in central Switzerland with no detected malignancy, only benign prostatic hyperplasia. A few weeks after the prostate biopsy, he visited his GP for signs of urinary tract infection, which have been treated with trimethoprim sulfamethoxazole for 5 days. After worsening symptoms after the antibiotic therapy for the suspected urinary tract infection, the patient was referred to our center for a second opinion. In the initial sonography, there was very low residual urine and a slightly inhomogeneous prostate. The urine dipstick was positive. The urine culture was negative as suspected after antibiotic therapy, and the diarrhea was extremely painful in this patient. So the patient got a prescription for ciprofloxacin for suspected postbiotic prostatitis for 10 days, twice daily. After a few weeks, the pain presented with worsening symptoms, hematuria, dysuria, perineal pain, elevated leukocytes, and whatnot. Dipstick was again positive, urine culture was still negative, and diarrhea was extremely painful. And the antibiotic therapy was switched to amoxicillin clavulanic acid. So coamoxicillin for 14 days, 3 times daily, 1 gram. After the third antibiotic therapy, there was a scheduled follow-up visit for the patient, and we scheduled an MRI because at the time there was an issue with the transrectal probe and we were not able to do a transrectal ultrasound because there was a suspicion of prostatic abscesses. The MRI showed acute inflammation of the prostate with small abscess formation, and the patient was scheduled for an urgent outpatient follow-up. Because of the prostatic abscesses, we decided to perform an abscess decortication, more or less staged TURP 2 days after the presentation because some organizational issues under a single dose prophylaxis with no extra antibiotics. And intraoperatively, there were a multitude of prostatic abscesses throughout the prostate, with one major abscess at the base of the prostate, which was basically more or less the patient developed in 2 days until the prostate surgery. The patient got a post-op catheter. For 2 days, the catheter was removed, the antibiotic therapy was stopped, and after that, it was a standard post-op course without any issues. In the follow-ups, after 2 and 6 weeks, there was a complete resolution of symptoms. Sonography was unremarkable. There was no sign of post-void residual urine. The PSA after 6 weeks was normal. The urine dipstick was negative, culture was negative, and the diarrhea wasn't painful anymore. So the key takeaways from this patient is we've been discussing a patient with chronic prostatitis who underwent transrectal biopsy, and we do not know which kind of antibiotic and for how long. He got an antibiotic for a few days, he said, most likely ciprofloxacin for 3 to 5 days. So it's very important to know what your patient has been doing, which procedures your patient underwent. So you need a very thorough record, very detailed history. In these kind of patients, always choose tailored approaches. In this case, every culture was negative, unfortunately, but there were no perineal or rectal swabs before the interventions. And also, as I said in the last talk, transperineal biopsy is the recommended approach if any kind of biopsy for the suspicion of prostate cancer is necessary. And with this, I would like to jump into the discussion. And thank you very much for your attention. And we are all very open for questions. Also, maybe regarding the case, because I think there are a few things we could have done a little differently that could have went better. So it's always a learning curve.
Yes, many other questions have been answered during the meeting, but I would like to just to get the importance on some of them. The first question I would like to add is to Elisa de Lorenzis, is inpatient before stone lithotripsy. What is your opinion about the prophylaxis in patient with a catheter, a double stent catheter with no symptom? It is indicated the prophylaxis, or is no prophylaxis, a short prophylaxis, or long prophylaxis? A patient with a stone in the ureter, small stone, with no previous infection.
This is a great topic. I based my first choice on urine culture, I guess. And if the patient is negative for symptoms, even if it's difficult to discriminate between stent-related symptoms and UTI symptoms in this kind of patients, and the preoperative blood exams are normal, I will go only for a single dose preoperative prophylaxis in these uncomplicated patients.
Okay, yes, I agree. The next question that appear in the question and answer is for Dr. Orcajada, as you are in infectious disease specialist. I think that you can help us in this. For example, we had a patient with a previous culture with an extended spectrum beta-lactamase enterobacteria. The patient now is okay, but a month ago, the patient had this culture. With prophylaxis recommend for this patient if we are going to perform an endourology surgery into the ureter?
This is a very good question. In fact, the presence of multidrug resistant enterobacteria is increasing. And I think that we are going to the personalized prophylaxis in the future. And in this case, I will take a look at the antibiogram, and I will try to use the less toxic prophylaxis that I could. Of course, if you can use 1 dose of aminoglycosides could be useful, or if not, trying to avoid the use of carbapenems, but if the patient has some renal function alterations, then you should use ertapenem, for example, as a prophylaxis, 1 dose.
Okay, thank you very much.
You're welcome.
Okay, and the next question to Fabian is before the transrectal biopsy, should we examine the EPS What do you think? Or with the rectal swab, it's okay? I don't know if the question is referring to the clinical case or just in general.
Yes. So, I mean, that's kind of void of data. It's hard to answer. It's more like an expert opinion. But I think that the swabs are sufficient. There are always cases with special patients, special cohorts. There was another question regarding prostate biopsy with indwelling catheters. And these are the cases where I say, like, great caution is warranted. So you should be very careful. You should take cultures, and you should have a very tailored approach in these patients because they are very prone to infection. But other than that, swabs are perfectly sufficient.
Yes, and another question is regarding the urine culture. I think that anyone can answer. Is patient with transurethral surgery, for example, the prostate, or before lithiasis, with the positive urine culture, shall we should wait to the culture if negative, or we can adjust the prophylaxis and go for the surgery? We are talking about asymptomatic bacteriuria, not about infection.
Well, I think that asymptomatic bacteriuria, if it is really asymptomatic, deserves one dose or 24 hours prophylaxis, depending on the procedure. But it is important to wait to the urine culture. It is important to know the antibiogram. Because ESBLs could be like the same that we said before. ESBLs could be susceptible to ertapenem, but also could be susceptible to aminoglycosides. Even they could be susceptible to cotrimoxazole, or they could be susceptible even to ciprofloxacin, that we can discuss later. But I think that a prophylaxis antibiotic should be directed to the urine culture. No wait. You have to wait to the urine culture, even if you don't have it complete.
Maybe I can add a point, because we're currently running a few surveys on the standard of care in treatment of asymptomatic bacteria before surgery. And I think it's always important to think about what kind of procedure, if it breaches the mucosa. If it's a small tier B, for example, I don't treat asymptomatic bacteria. I just give a single shot pre-op. If it's a small stone, like a quick rigid ureteroscopy, I don't treat asymptomatic bacteria. If it's a tier P, I treat asymptomatic bacteria, but I start 24 hours earlier. I don't think there is any place for extended prophylaxis, 7, 9, 10, whatever, how many days. And there is quite a variety of Europe in these kind of standards. There are centers that treat asymptomatic bacteria before surgery for 2 weeks with continuous antibiotics. So it's very individualized, and it's not very easy to just say, for this procedure, give this antibiotic. It's what patient, which procedure, how long will the procedure be, how extensive, how invasive, and so on.
I agree with Fabian. Thank you.
In general, I think that waiting for a negative urine culture is not a good choice, because we wasted time and we don't change our results.
Of course, I agree also.
I would love to thank all the speakers about the good presentation. That is very practical. I also like to thank to the European Association of Urology, the organization of the webinar.
Thank you.
Thank you.
Thank you.
Thank you very much, and have a good evening, everybody.